Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Paul Havey, Chief Customer Officer at Revecore. Paul, welcome to the show.
Matt, thank you so much. Glad to be here.
So, Paul, what I always like to do before getting into the main part of my conversation is to give my guests more of a chance to provide an introduction in terms of who they are and what they do. So, Paul, the floor is yours.
Sure. I could start with Revecore. We are a trusted partner to about 1,300 hospitals and health systems throughout the country. Our focus and specialty is on complex revenue cycle management. We achieved that through purpose-built technology, and it's informed by decades of operating experience. We leverage AI technology-enabled models, scoring platforms, and deep subject matter expertise, and delivered that through an outcome-aligned partnership to our hospital partners. In terms of industry accolades, we are a 5-time winner of Best in Class. It's kind of an industry standard bearer in our space for our complex claims services. And since our inception, we've helped hospital providers recover billions of dollars in revenue by resolving their denials, underpayments, and complex claims at scale and efficiently. From a mission perspective, we endeavor to master the complexity of healthcare revenue cycle management to help hospitals protect and maximize every dollar that they've earned through the patients they serve, and helping them navigate intricate financial, operational, and regulatory challenges associated with healthcare reimbursement. For me personally, I've had a sort of varied career, almost always in some form or facet of healthcare and revenue cycle. From large consulting and corporate environments, also to entrepreneurial endeavors where I was a co-founder in a specialty revenue cycle startup. And I'm currently as you introduced, Chief Client Officer at Revecore. My goal and what I'm responsible for is ensuring the success of our hospital partners and ensuring that they're optimizing the value of our solutions.
So the other thing I'm always curious about is what got you into healthcare in the first place?
Interesting. Brief history is I come from a clinical family. Funny aside, my parents met in nursing school. I think I knew intuitively early on that I wasn't going to be a clinician. And then somehow I just found my way into this space. Wouldn't have predicted it, but it somehow suits me. So maybe that's, there's some genetic component to it.
Yeah, no, I certainly relate to that because it's. I also come from a family with a clinical background, and my wife is also in the field. But like you, stumbled into it completely, and it sounds like probably similar to you. Just once I actually got into it personally, really connected to it, and enjoy being within the healthcare industry.
Agree. Same here.
So Paul, I know you're talking a lot about kind of the work that you do is focused on claims and denials and kind of working through that process. So maybe if we kind of take a step back and thinking about, revenue cycle and just that entire ecosystem, when we're talking about, revenue cycle management or the life cycle of a claim, what does that actually mean and what does that look like?
Sure. I like to think of it as a almost parallel or short staggered sequence process that really follows the clinical life cycle and the patient journey. And it captures and includes all the dimensions required to appropriately categorize and document the services provided, which then translates into invoicing between the hospital and the insurance company or payer, and then all the way through to making sure that's appropriately paid and reconciled in the hospital system.
So when you're looking at the kind of that cycle and that process, what are the most important parts, or what are the parts that you focus on the most?
So we as Revecore focus very heavily after care and at the early stages of the billing life cycle, in the post-bill cycle. And we typically intervene from a service perspective once the claim has been submitted to the payer and there's some issue to help the hospital resolve to get accurate payment.
So when you're talking post-submission, what are the issues that can pop up? Because I know you talked about denials, which, seems to be a popular thing because that's hitting even the general news. So what is a denial, and what are some of the other kind of issues that you'll look into in that post submission stage?
Sure. First off, there's on the complex claim side is the correct payer, have they been identified and appropriately invoiced? In the case of an accident or injury claim, there may be other parties that are liable in a primary way before traditional health insurance would reimburse. And then there's also the case of denials, which you touched on already, and I'm sure we'll talk about more. And then there's this other facet of our services referred to as underpayments. Even when the hospital is paid, there's an open question of were they paid accurately given the services that were rendered. So we have 3 service areas focused on those unique and subtly different revenue cycle challenges.
So, kind of picking up on what you mentioned about denials, what actually constitutes a denial, and then what do you do when you're working with the systems or the providers to respond to a denial when it is received?
Sure. In simplest terms, a denial is a refusal by the health insurance company to pay the claim as invoiced from the hospital. Now, there may be very legitimate reasons for these denials. Between every payer and provider, there's a clear and defined set of rules as to what services are eligible and what processes need to be followed by the provider to be appropriately reimbursed or paid. When those criteria are not met, plain and simple, claims will get denied. Examples abound. Some of them are prior authorization requirements, services not being covered, patient may not be enrolled. If you sent an invoice to the insurance company and that patient isn't in their roles, well, they're certainly not going to pay. There could be coding issues upstream in the life cycle of the claim, other forms of administrative errors, and at risk of being overly exhaustive, the list goes on. There's also denials that occur for perhaps less obvious and potentially more subjective reasons. Examples in this category would include one you've probably seen in the press recently, medical necessity. Sometimes you also hear a sort of tangential reference to level of care. These are examples where the payer disagrees with the clinical judgment and decision-making that was brought forward by the treating physician. These can also be a significant focus area for both the payer and the provider, as these claims can traditionally be often of very high value in terms of the potential reimbursement at stake and also the inherent complexity of the case itself in the instance of complex surgeries or lengthy inpatient hospital stays. There are also denials that we observe and simply do not understand or agree with, given the clear rules and requirements I referenced earlier. I would put these in sort of an error category or basket, and whether they are true errors or accidental, well, that's subject to debate.
Yeah, no, because it sounds like, as you said, that third bucket is really a gray area between the legitimate and the subjective denials. Agreed. Because it sounds like you really need to parse them through. So from your description, it sounds like if you get a legitimate denial, that one might be easier to figure out and either understand, oh yeah, that there is a real basis for it and I can't fix it, or I see what the error is, and now is there that opportunity to go back and fix the claim so it will be approved when you receive that, as you said, the denial in the legitimate bucket.
Absolutely. And that's where we as Revecore, as a partner to hospitals, will help intervene in the life cycle of that denial. Might traditionally refer to that as an appeal. That's the action we would take in response to a denial on the provider's behalf.
So it sounds like that appeal process for a legitimate denial might be easier. If you're dealing with a subjective denial, does that go through the same type of appeal process?
Yeah, and that's where we've seen some growth and trends in the industry. Let's see. If maybe we were to step back in time and sort of the how events have emerged in the denial space specifically. There's a couple key factors that we've observed. One is what I would frame as a macro trend. And this has been driven by the steady conversion of traditional government type plans, so Medicare and Medicaid, to more commercial and privately managed programs. So you may hear this are often referred to as managed Medicare or Medicare Advantage, as well as managed Medicaid. Medicare has led the way, and now we've seen a subsequent wave of states pursuing that conversion. These plans all employ those rules and processes referenced earlier. So what effectively has happened is that the population of beneficiaries has grown, okay? Therefore, translating to aggregate volumes of denials increasing. Second, and from a sort of brief history perspective, there's been an ongoing evolution and really back and forth between providers and payers in the types of denials that are that have been issued, and there's a strong complexity correlation as well. The idea of a denial isn't necessarily new or novel, but the significance of their impact has grown materially over the last, let's say, 10 to 15 years. I'm probably dating myself a bit. When the majority of denials earlier, the majority of denials tended to be more administrative in nature, lower complexity profile, and over time, providers had tightened up their processes to address those. And I think the garbage in, garbage out expression applies. If you clean up your data inputs, your downstream processes are going to be better. In terms of the evolution, payers began to introduce more stringent and complex prior authorization requirements. So those types of denials surge, and they still remain prominent today. And providers and payers continue to respond and go back and forth in this space. From a more present tense perspective, I'd say we're in a kind of a bifurcated phase. We do see the higher complexity. So I referenced medical necessity earlier. We've seen and experienced steady growth in that denial profile. At the other end of that spectrum, we've also seen some significant growth in trends of what we would in the industry would refer to as low dollar denials. These are cases where the providers have basically a structural disadvantage. From an ROI perspective, they just can't financially justify taking the time and allocating the resources to appeal that dollar denial. It's a gross example, but if the cost to appeal a $50 denial exceeds, the potential reimbursement, it just isn't financially prudent to do so, right? The law of unit level economics should and often do prevail. So we've seen systemic patterns where those denial types have grown, and it's kind of the death by thousand cuts metaphor. A $50 denial is not a lot, but tens, thousands of them, you're talking significant sums of reimbursement.
Yeah, no, and that certainly makes sense because, as you said, like the individual claim might be low value, but when you aggregate it across
exactly
multiple instances, it grows. But it also sounds like inherently, it's not like you can appeal on an economy of scale necessarily because you're going to have to put in an equal amount of work for each claim. So, you're not kind of recognizing the return on that value.
Exactly.
And for those of you just joining, I'm talking with Paul Havey from Revecore, talking about the claims life cycle and really focusing on kind of evolution of issues around denials. And Paul, I know you're kind of just talking about complexity issues and low dollar value claims. And at the beginning when you're kind of talking about the scope of services you're focusing on, I think you're talking about the use of technology and AI and helping to provide those. So, kind of like it feels like everything in healthcare, how have those technology solutions impacted or influenced, the claims lifecycle process?
Absolutely. So what we've been seeing recently is payers increasing their capacity to issue denials at increased scale and efficiency. That sounds to be led through AI enablement of their processes. And that certainly has tilted the table a bit and has really inundated providers with higher volumes of denials to deal with. That obviously places challenges and burdens, and then creates the need and opportunity for advancements in the tools to combat them. We as Revecore participate in that space as well, along with our hospital partners.
So, kind of that, I think you said AI enabled, efficiency, and, it seems like it's a nice way of phrasing that. But then as you said, the development of combative tools to be able to help counteract that, does that mean we're to some degree getting to a place where two different technology systems are just going at it? And, that's the first level before maybe you'd have some type of human intervention?
I do. I think sort of this notion of an arms race as a metaphor is very apt here. It is a back and forth game, and the same tools and technologies to issue the denials are being brought forward to really combat them as well. Introduce efficiencies and automations in process areas that were particularly challenged in doing so. There's still pockets of subject matter expertise required throughout the revenue cycle process. Coding is one of them, clinical expertise in terms of nurses and physicians, and the ability to further enable their review processes are some of the unique and special applications of AI-enabled technology to help combat those denials.
Yeah, so it sounds like, AI or whatever form of technology you're looking at has the opportunity to help get the issue to the core of it more quickly. And the area where, I think as you were just describing, you do need clinical expertise, or you need, specialty knowledge. So, do you think there is kind of that optimistic view that can be taken where maybe the technology will help to level that playing field and get through kind of the noise more quickly, so you can really get to examining, the important aspects of, what might be under dispute between the payer and the provider?
Absolutely. So we're seeing some of that within our walls, and the solutions that we continue to develop and mature and iterate forward. So we do see it as a playing field leveler. From a present tense perspective, I'd also offer that we don't view it as a panacea, at least not for now. I think we'd be naive to not think and expect AI will continue to evolve and improve, and will continue to be a key enabler for improving revenue cycle outcomes. However, we also see in the present tense an ongoing need for human level subject matter expertise to ensure those tools are being optimized and being used effectively.
Yeah. So, given the need, as you said, for that human level of expertise, is there enough of that expertise to go around, or is it being, effectively utilized?
I would say no to the first question. Is there enough of it around? And then no to the second question as well. There's and in fact, that translates to demand for services like ours. Those skill sets and expertise can be very scarce to source locally. So, which is what will trigger demand for solutions with providers like us. And then secondly, we're seeing improvements through the use of technology and optimizing that expertise. And I think we're going to continue to see a steady transition instead of I'll use a clinical expert as an example, as instead of an individual contributor handcrafting and authoring an appeal, that will begin to evolve our use of AI-enabled technology where they're experts informing how those tools work and serving as quality assurance and more curators of the outputs rather than the creators of the outputs.
Yeah, I think that's a kind of an interesting approach to it, because it's, I think as you're implying, it then becomes, more trustworthy to a larger degree. And that trust, and hopefully that trustworthiness is recognized on both sides of the coin. So, maybe kind of the future state question out of that is, is there, do you see technology as potentially playing a role of hopefully growing trust and willingness to work together between payers and providers? Because I think the traditional viewpoint is that they're always fighting with each other and that there's a lot of distrust between the two sides.
Yeah, that one is, I think we've seen and heard and hoped for some improved transparency and trust that could be enabled through data sharing models like this. At the same time, it is a complex model with lots of stakeholders. While I'm optimistic, I do think there will be a focus in the near term of really continuing to optimize on the status quo rather than maybe systemic changes that would really transform some of the burdens that are currently resident in the system.
And so kind of recognizing that likely inherent limitation, because it's as we've seen in healthcare, change can be hard, and it's a lot of people are used to that status quo. If we could get optimistic and predict what changes could occur, from your perspective, what would you like to see? Like what are some of those key systemic changes that you think would make the process better for both sides?
Sure. As recently as last week, we saw some political activity on this front where some of the major insurers were called to the carpet by Congress for various topics and issues. But prior authorization and the onerous requirements were specifically mentioned, and a lot of frustration from Congress towards the insurance companies. So I think relaxing some of those burdens could afford some systemic changes and a little more efficiency through the process. So that would be sort of macro level. But as you alluded to, it does feel sometimes like wishful thinking, as it is a complex and financially incentivized stakeholder model to navigate. And what we've seen over time is these system level changes really take place over decades. These aren't weeks and months type initiatives.
Yeah, no, and I think that is certainly true. And it's, it also sounds like kind of when you're going through some of those, historical trends versus some of the more recent ones, there has been some movement, and it's, I think to your point, incremental, and it's, maybe to some degree, slight shifting of the issue. So it maybe narrows down a little bit or it becomes more focused. But, there is, some basis for optimism that improvement can and is occurring within, that entire claims lifecycle process.
I agree. And I tend to and prefer to view the glass as half full, no doubt.
Yeah. So, kind of thinking about, where trends might be going, do you have any predictions of, where you see maybe things could start loosening up, or where you're starting to see new problem areas might be arising?
If I were to predict, I think we'll see an evolution of how the tools and technologies are used. And I think directionally from a reactive to a more proactive and predictive model. So even in the status quo environment, I think we'll see a maturation of the tools, leveraging of historical data to really begin perhaps looking ahead. So in the scenario where denials persist and continue to be a trend in the industry, can the providers actually be forward-looking and have some sense of predictability about where risk areas are from a forward-looking perspective, and using that to inform their internal processes, and again, with a tendency to be more proactive rather than the current reactive model. So I would predict time will tell. How long will that take? But I think it will enable a more forward-looking approach, anticipating in an ideal scenario, heading off these issues at the pass, and the example of denials and other issues that may emerge.
Yeah, no, and kind of that shift to proactive and predictive models, that certainly sounds promising because, as you said, similar to a lot of discussions about the delivery of care, of wanting to be proactive, if you can catch issues before they become a bigger problem, or even be able to, anticipate and then avoid by changing behavior, then that's just going to, hopefully improve the process for everybody, and, reduce those instances of, kind of your extreme example of those low dollar value denials where you just don't have the resources to fight it because it's going to cost you more to do it than you'll get in the return. But Paul, believe it or not, we're already almost out of time. So
Amazing.
I'm going to close with a final question of, kind of given everything that we've talked about, what is maybe the biggest misconception or the biggest point that people get wrong or don't fully understand when it comes to, the claims life cycle?
Interesting one. Biggest misconception is that I would say that one thing I hear is that that denials are just universally preventable. I think our experience over time is that despite numerous prevention strategies that may be deployed, the denial landscape continues to evolve, and new sources of denials have continued to emerge over time. So, in an evolving landscape, it's hard to solve a problem, conclusively and finally.
Yeah, no, I think that's a great insight. Where, as you just said, it's, denials are going to happen sometimes, and sometimes they need to happen because something is missed, or, something did, just didn't occur. You're just missing a piece of information. So it's, I think keeping that in mind is important, even as you're looking at all the other issues, that you're able to highlight today. But, as I said, Paul, believe it or not, we're already out of time. So I want to thank my guest, Paul Havey, for a great conversation today.
Matt, thank you so much. I enjoyed being here.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.